Thank you, everybody. Well, cystoid macular edema is a non-specific clinical finding, and it results from a final common pathway of many intraocular diseases. If you look at the etiologies, there are various etiologies, but most commonly it is the vascular and inflammatory causes of which causes the cystoid macular edema. Another broad classification is into pseudophakic and non-pseudophakic CME. This talk will be restricted to the post-surgical CME. Well, this is how a patient of CME would present to a retina doctor. This would be referred by your cataract section 4 to 6 weeks after an eventful or uneventful cataract surgery. And this time I'd get a call from the doctor saying, fovea looks unhealthy and there is no improvement with refraction. And we are to face this disgruntled patient, and he would be informed three things: cataract surgery and IOL okay, some retinal problem exists, and our specialist will see you. We have to cool his tempers, get back his confidence, and find some very difficult questions. He'll complain, I was seeing better before cataract surgery. We operate at 6/9 now. He'll ask you, anything wrong with this surgery? Will I recover vision? How long will it take to recover the vision? And he'll keep asking you this question again and again. Anything wrong with the surgery? Could we have avoided this situation, and how to manage this patient? This is the brief overview of what I'll be speaking. We'll look at some of the classifications, then look at the causes, and then have a stepwise and evidence-based approach to its management and prevention. Cystoid macular edema continues to be the frustrating and most common of all complications. If you look at the definitions, angiographic CME means the patient is asymptomatic but has detectable leakage on the FFA. But if the patient has a visual impairment, then it becomes a clinical CME. Depending on the timing, they are again classified as early CME, late CME, and chronic CME. The patient who has got cystoid macular edema, which persists for more than 6 months, is called as chronic CME. Very long-standing patients may lead to have this fusion of all the cysts, leading to a foveal cyst, and these are associated with poor visual acuity and prognosis. Coming to the management of CME, well, the diagnosis is easy, but the main aim of the treatment is to answer this question: why this patient has a CME? So the causes could be operation-related, or it could be patient factors. So let us look at what are the per-op surgical complications that one can have. It could be ruptured posterior capsule, the vitreous loss, or it could be iris tissue damage during surgery, a retained cortex, decentered IOLs, a retained nuclear fragment in the vitreous, vitreous wick, prolonged surgery, and use of adrenergic drugs. It can also happen after a perfectly done surgery. Other causes, if you look at the patient-related causes, an elderly patient is more prone to have a CME. Then compliance. Sometimes there's lot of misunderstanding that happens. You say too hourly, patient thinks it is 2 times per day. Sometimes the patient stops the drops after 2 weeks when he gets the glasses. Sometimes we give them the kits, the drops given with the kit are over, then he did not buy the medicines later. It's also important that we review the other eye surgery notes if we are done. If the patient had a CME in the other eye, there's a more likelihood that you'll have CME in this eye also. We also have to look at the other comorbid conditions like diabetic retinopathy, the vein occlusions, etc. Also, be aware that CME can happen after a YAG capsulotomy. Coming to my patient, this patient had a perfectly done surgery. His post-op review notes revealed that he had AC occasional cells. But when I did the examination, under a good slit lamp with room lights off, he had a 3+ cells. So what is important is to assess the extent of inflammation correctly and to individualize the medication interval and tapering based on the inflammation. As far as management is concerned, if you go by evidence, there is no standardized treatment for treating these patients, neither there is any standardized prophylactic protocol. No RCTs are there with long-term follow-up. Usually, a step-ladder pattern of treatment is applied. We start with topical corticosteroids and NSAID combination. If it doesn't work, then we go on to give subtenance. Some people also have tried oral acetazolamide and later intravitreal injections. If you look at the treatment options, it is better always to give NSAID with steroids for better action. But when it comes to preventing CME, NSAIDs alone are better, and adding a steroid would not make any difference. Which of these NSAIDs is better? If you go by the evidence, ketorolac has got better penetration into the antechamber and the vitreous and better inhibition of PGE2. However, both these drugs have got better market penetration. As far as anti-VEGF is concerned, there is no robust data to support its use. It should be reserved only in eyes which are unresponsive to conventional treatment. Sometimes you can have this kind of presentation. This patient presented with CME 1 year after the cataract surgery. However, the treatment protocol would remain same. Sometimes you can have chronic CME, which is refractory to topical medication.
Some of you can come in the front.
Would require periocular steroids or intravitreal steroids. But we should be careful when treating these chronic CME patients. This patient came 7 months after cataract surgery with a chronic inflammation, 6/18 vision. She was treated with steroids and was responding, but oral steroids she couldn't tolerate for long. So after giving treatment with IVTA, her vision improved to 6/6 immediately, but later what happened was she worsened. And what exactly happened was this patient developed fungal hyphae. So you should be aware that in chronic CME can be harbinger of the Propionibacterium or fungal infection. If you have a poor response, it could be a vitreomacular traction, and these patients need to be operated only. So as far as prophylaxis is concerned, you divide the patients as normal and high-risk cataract patients and adopt a separate therapeutic scheme. If you have patients with the following causes, so make sure you stop prostaglandin analogs in patients with glaucoma. If the patient has uveitic cataract, then have a perioperative steroid cover with a slow taper. And patients with diabetic macular edema or vein occlusions, consider anti-VEGF. So, summary, answer this question, why this patient has CME, that will lead to the answer, and you have to treat them. And follow a step-ladder pattern of treatment in these patients. Thank you very much.